Hi, this is Kim McAllister. I want to welcome you to Chapter 3. We're going to talk about evidence-based practice, practice-based evidence, and informatics, how this all ties together. If you were with me last semester in research, then you understand what evidence-based practice is and why it's important and how we do it. We do evidence-based practice because this is the best way that we've determined for improving our science and improving patient care. And evidence-based clinical decision making means that we base our clinical decisions, our clinical guidelines, protocols, and so forth on the idea that research-based care improves patient outcomes. And so we actually test out what interventions will diminish the health problem, what interventions will prevent the health problem, and just all the things that we can do to improve care. It can be prevention, it can be keeping things from getting any worse than they are, it can be creating new guidelines, new parameters. It can be a whole host of things, but we're going to focus now on how this relates to informatics. In the 1990s, the Institute of Medicine did an enormous analysis of our healthcare system and found that we fall very short in quality of care. And if you've been in practice for any length of time, you have dealt with on a daily basis dealing with meeting parameters that measure outcomes for quality care. So we get some of these outcomes through our evidence-based practice. We also have to indicate that we are meeting them. And some of the ways that we track that and indicate and provide evidence of outcomes and evidence of our compliance is through our informatics and the electronic healthcare system. But what the Institute of Medicine found out is that quality of care lags behind knowledge. And so evidence-based practice is the proposed solution. Evidence-based practice gives us some type of guideline for how we're going to change things and what we're going to base that on. In the past, it was basically people did what seemed to work out well. They used anecdotal evidence, and people would follow along because it seemed to be a good idea. And now we're moving to make sure that all of these great ideas and things that we're following have a reason behind them, that we're not stuck in tradition, that we're not doing something because we thought greatly of the person who came up with this idea, and we're not doing things based on what's convenient or what we can readily do. We want to look at how to actually improve care and do it in an orderly method. So we have the Agency for Healthcare Research and Quality, AHRQ. They do an annual report, and they gather data from 36 databases. And they have found also that quality in America is suboptimal. And that's kind of tragic because we're supposed to have the best healthcare system in the world. And yet our system, as we all know, is flawed and has its problems. What they have found out in their work is that the gap between best possible care and routine care is significant. But we have had some small gains being made. And you can go to their website. Let's go there really quick, just so that you can see that. There's a lot of information on this site. This is a good site to bookmark. They have all kinds of information that you can get. If you have to prepare any type of in-service or information for practice, let's say you're looking at moving up on your clinical ladder and you're required to do in-services, this is a really good place to find some information. You can find out certain initiatives. You can look at their research. They have certain tools for clinicians, healthcare systems, and so forth. Here's some quality toolkits, all kinds of things that you can find. Oh, go away. Like, let's say, Here's our end-stage renal disease facility toolkit. And there are modules, all kinds of information. There's slides, there's notes, there's videos doing culture of safety, all kinds of rich information for you in your practice. So be sure that you bookmark the site. It's ahrq.gov, and you can find that. And I'll put this in the links in the course. So in 2001, the Institute of Medicine issued a report. They issued Crossing the Quality Chasm. If you have not read that, I recommend that you do. You can download it online. You can purchase the book. It's very eye-opening, and it's the reason why we have a lot of things that we do now, like the pharmacy dispensing machine, your machines that dispense the supplies and so forth. All of this came out of the IOM Crossing the Quality Chasm into Air as Human reports. And they were used in part to promote safety, prevent medication errors, and also to help us track quality indicators, also to help with billing and insurance and all of that. So it's done, a lot of this is produced good for us. So they've talked about the STEEP redesign, having safe, timely, effective, efficient, equitable, and patient-centered care. There are hurdles to all of this evidence that we're sifting through now, evidence that we're creating. We're doing research. You're probably aware that there are a lot of research grants available, like Johnson & Johnson, HRSA, and others that will help you fund care if you're interested in a particular area of research that are covered by these grants. So this has produced all this literature. So what do we do with it? We can't all sit down and read it because that would take forever. And we also have to decide which literature, what research, what is actually appropriate for changing our clinical decisions. And so they came up with the ASTAR model of knowledge transformation, not transportation. And the first on the model is discovery research. This is where you're conducting experiments, non-experiments, doing randomized control trials, and so forth. And then you make an evidence summary. So you look at all the different research and summarize the research. Then that research is used to create translation guidelines. And that translation guideline means they're translating, they're taking the research and putting it into clinical guidelines, into protocols, into standards of practice, into procedures and policies. That's what translation means. And then after that happens, it begins to be integrated into practice. And then we can do some type of evaluation and see how that goes. And based on that evaluation, then we go back to the research and start the whole routine again. Because we as healthcare workers, as nurses, we are continually evaluating what we do, and we do that again here. So knowledge transformation is where we take the research findings from a single study and we go through a series of stages and determine if it's capable of impacting health decisions. So the premise of the knowledge is that of the model is that knowledge transformation has to happen before we can do something meaningful with the research. We have to be able to put each of these studies into some type of practice, and sometimes they can and sometimes they're not. And we don't just take pure research and create our practice models, our clinical guidelines based on that. We also add our experience, our knowledge. When we are working with patients, we're also partnering with them. Some of the things that we think are good or things that will be helpful are things that will not work for the patient. It may be care beyond what the patient wants. It may be in conflict with their culture or with their routine or with their expectations. So we all have to work together to build this. Understand the best knowledge is going to come through systematic processes, such as the research process. You may remember in that class we talk about bias and how to control it. And that bias and rigor is very, very important, because the more rigorous and the most exclusive of bias is going to give us the most stable and highest level of research and information that we can actually use. And this just goes on to talk about the hierarchy of evidence, which we'll go into a little more in a moment. So the ultimate use of evidence-based practice is going to be to apply to healthcare, to improve outcomes, to improve lives. And so the form of knowledge depends on how usable it is. If it's just a primary study, if it's something that's only been done once, it's the very first time, would you be as willing to take those recommendations into practice as you would something that has been repeated and found that it's solid not only in this one instance but in more? And I think you know the answer to that. So we transform the knowledge, first of all, by summarizing it into a single statement about what it means, about the state of the science. What is it? And then we translate that into clinical recommendations. So we have an overall statement of what does this mean to us? What does this mean to practice? What happens with this? And then we start putting this into the clinical setting. Think about, if this is true, how does this impact what we've been doing? And it's not just one person who sits down and decides, hey, these are all the things that we're going to do. This needs to be a multidisciplinary approach. We need to have other organizations looking at it. These recommendations will be sent to the professional organizations that deal with the illness, and they'll each look at it and come to their own conclusions and then share their conclusions. This is not something that happens overnight. This is a process that takes a while. And then they're going to start to evaluate these guidelines. Does this work? Does it not? So it can take a long time before the actual guidelines are fully implemented. And then we have to get buy-in from all of the practitioners and people in the field to begin using them. So with point 1, again, knowledge is produced through primary discovery. We can also get knowledge from evidence summaries. This is where we synthesize the evidence. We talk about and think about what were the strengths, what were the weaknesses, what was the situation in which this was used. Would this apply to other areas of nursing, of healthcare? Will this only work in one particular type of unit? Can this be applied to all areas of nursing? Can this be applied to all patients? Are there some settings where this will not work? What were the limitations of the study? What were the need for further study? You have to analyze and look at all of that before you can decide to move forward. And then the translation comes when you have experts pulled together to go through all of the evidence summary. And then there are gaps. We can't research absolutely everything. And so we rely on knowledge and experience and experts to give their opinions and start to put all of this together. And this is just a picture of evidence summaries. Of the strength of evidence. You have your evidence summaries, research trials, non-experimental. This is experimental, non-experimental, and then qualitative. If you remember, qualitative is the type of research where you're looking for themes, and you may be doing a lot of interviews and talking and sitting down with people and trying to get ideas and find out what the impact of things are. And qualitative studies are often used then to determine where we should go with non-experimental or experimental studies. And then again, integrating into practice, that can be in individual organizations, it can be policies. It just depends on how big the issue is, how big the knowledge is, Is it something that's only going to work in your particular unit? Is it something that's going to work in your hospital? Is it something that would apply to nursing nationwide? And so based on that, you're going to look at who you're going to be involved in helping to translate that information. Evaluation. So you've put new protocols in place. You've redesigned care. How effective was it? And the only way you can know that is if you have, along with your guidelines, if you have to set some type of criteria for evaluating it. Did that work with your patient population? Did it work with the population in general? Was this so expensive that it won't work? Was this so expensive it was a burden? Was it very reasonable, and did it work well, and was it well accepted? How was it received? Were the patients happy? Was the staff happy? Did it bring about the desired result? There are a lot of factors that will determine whether or not this will be successful. So these are all things that have to be looked at. So again, the evidence-based PrAC framework provides our guidelines for how we're going to do that. And just like we have done this with clinical solutions, we also have to look at this with informatics solutions. We have things like, how are we going to share information from one institute to another? How are we going to determine what our interoperability standards are? Interoperability means the ability of units within the hospital to work and communicate together, hospital to hospital to communicate. What about when we send our information electronically to insurance companies so things can be billed? Does our system work with all of our insurance providers that we're going to use? Does this work with our practitioners and their software? Do we have patient portals? Will this information go to them? So we don't only just use this in clinical settings, but also think about how we're going to do this in informatics settings. Have you been through a change in electronic health record vendors? I know that's excruciatingly painful. We did this in one hospital and we couldn't get patients discharged from the emergency room. We also had patients that were stuck in surgery, not in surgery, but in the holding area for hours because the system would not release them so they could go to surgery. So when these things don't work right, we can have some big problems. So it's very important to be evaluating and looking at your informatics system as well as your other systems of care in the hospital.